All right, for the second testing unit, we're going to be looking at the cardiovascular system. For this class, we're going to be focused in on the functional aspects of the cardiovascular system, not necessarily the electrical components. So the electrical stuff being like abnormal EKG rhythms, dysrhythmias, things like that. That's going to be covered in MedSurg 2, so in a later course. So for the functional part of the cardiac system, or specifically around the heart, we're looking at kind of the cardiac cycle. And that consists of three different kind of phases that I really want to focus in on. There are some more, but these are the three that I really want to focus in on for this course. So preload is the first phase of cardiac contraction that we need to pay attention to. And this is where the atria or the ventricles kind of stretch as a result of the fill that comes into those spaces. So they get a little stretch, i.e. they get a little more pressure in there. That way when the heart contracts, it has a slightly more kind of active or a slightly stronger compression associated with each heartbeat. And what that produces is our cardiac output. So cardiac output isn't measured like every single atria, every single ventricle. Most of what we measure for cardiac output is really what's produced by the left ventricle. It's how much circulating volume, how much blood volume is being provided to the body with each heartbeat. So at the end of vascular diastole, so diastole meaning vascular contraction, ventricular contraction. Normal, we want about 100% is our goal, but really you're never gonna get 100%. So somewhere in the like upper percent, so 70, 80% is a great cardiac output for a patient. So what we're looking for is around 4 to 8 liters per minute. Now this isn't a measure that we do as nurses. It's not something we calculate through our vital signs. It's something that physicians, specifically subspecialist physicians like cardiologists, are the ones who are going to make these calculations and let us know exactly what a patient's cardiac output is. To put this in perspective, patients who are considered to have advanced heart disease from congestive heart failure, things like that, usually we're measuring cardiac output somewhere in like the 20% or less kind of range. And those are people with very, very advanced disease. And then afterload, so this is how hard the heart muscle has to squeeze in order to pump blood. So how much pressure does it have to generate in order to keep circulation going? So those are kind of the three big terms that we want to talk around the cardiac cycle. So just to visualize that, so systole is contraction of muscles. So in this image, it's showing contraction of the ventricles. So our right ventricle is ejecting blood to the lungs, our left ventricle ejecting blood out the aorta to the body. So first branching up to the brain and then down the aorta, around the curve of the aorta to the rest of the body. Important thing to take note of that we're going to talk about later when we get into specific disorders is that one of the first branches off the aorta is our renal arteries, so it's our kidneys. So we're going to be talking about that quite a bit around flow disorders of the body. Then diastole. So diastole is the heart muscle relaxes. When they say heart muscle here, they're really focused in on the ventricles. So the atria in this case are actually contracting in order to move blood into those ventricles and create that preload, which is that little bit of stretch, that extra stretch that you can see here that's going to help with that final systolic ejection of blood to the body or out of the heart to the body, whether it's the lungs or to systemic circulation. So how does it do it? So this is the conductive pathway for the heart. So anytime we talk about conductive, we're talking about the electrical impulses associated with the heart. So the SA node, I know this is a little bit of review from patho, but just to kind of refresh, dust that off a little bit. The SA node, which is up in our right atria, is our pacemaker of the heart. It sets our normal heart beats, and normally it'll beat, normal heart rate should be around 80 to 100 beats per minute, and that's all going to be generated by your SA node. Then comes our AV node, which is right at kind of that border between our atria and our ventricles. And this is going to coordinate all the impulses that have gone around the atria to deliver those to the ventricles through the bundle of His, just distal to the AV node and then out into the Purkinje fibers, so you get that coordinated ventricular contraction that really does start from the apex of the heart and squeezes up in order to have more efficiency with that contraction. So this is kind of what that looks like. We are going to be talking about heart attacks in this unit. So one of the key things that we do for heart attacks through diagnostics is look at EKGs. So that's really the only electrical conductivity pathway thing that we're going to be looking at this term. But just to review what normal EKGs look like and kind of what's going on during each of those phases, if we start here where there's not really any activity going on, this is after our T wave or before our P wave. It's these flat sections. We call that the baseline of our EKG. So then the first thing that happens, which is labeled number 2 here, is our SA node generates that electrical impulse, which coordinates our atria to have a muscle contraction. And the way we visualize that is our P wave. So that tiny little bump that comes before everything, that indicates atrial contraction. So then we have, and that also opens up our valves between our atria and our ventricles, which is going to cause contraction of blood into the ventricles from the atria. So while that blood is moving down from the atria to the ventricles, that's this little flat space here between our P wave and our QRS. We call that our PR interval, or PRI. And we measure that from the start of the P wave to the start of our R wave, which is this kind of vertical spiking one. So we measure that as our PRI, which you guys will do in med-surg too. Then we get to this next section, which is our QRS complex. This is the big one. This is like the big monster. This is where our electrical activity is getting coordinated at our AV node, going through the bundle of His down to the Purkinje fibers and really starting to have that contraction of the ventricles. It takes a lot of electricity to cause ventricular contraction relative to atrial contraction. That's why we see this much larger complex associated with ventricular contraction. So then that happens, and then as soon as that blood starts moving, that's when we're at our ST interval. So this flat space where the EKG will return back to baseline. And that indicates that blood is moving from the ventricles out into the body. And then our T wave, which is up here, this is what we call ventricular repolarization. So this is the relaxation of the ventricles. Because there's so much muscle activity there, we do still get to like observe a little bit of electrical activity associated with that repolarization right in here. Okay? For the purposes of this course, the key area of this entire electrical conductive pathway of the heart that we're going to focus in on around heart attacks is right here. It's these two phases right in here where we have ventricular contraction, relaxation, or repolarization. We're going to be looking at that ST segment. So right here, measuring from our S to the end of our T wave, this ST segment, because that's the part that becomes altered when patients have a heart attack. So super common exams that patients with cardiac or circulatory disorders tend to get is, one, for functional, we want to look at their blood pressure. What is their heart actually able to produce, and how is their heart able to move that blood around their body? How is it able to perfuse all the tissues in the distal part of the body? Echocardiograms, which are an ultrasound of the heart so we can visualize the muscle movement of the heart and blood flowing through the circulatory system. So we can do this a couple different ways. We've also got our TEE, which we're going to talk more about, but that's a transesophageal echocardiogram. The kind you're typically used to seeing where they have an ultrasound outside the chest, they're doing it on the chest wall, is a transthoracic echocardiogram, or a TTE. Transesophageal is actually an ingested probe, so it's in the esophagus, and we're looking at the heart from inside the body. And then our stress tests. So stress testing is a way to place the heart under stress to make it beat faster as though it's working harder. And we can do this a couple different ways. One is exercise. Put people on a treadmill while they're on an EKG machine so we can monitor that electrical activity and have them run. Stress the heart, and we can watch what goes on. And then if patients can't get on a treadmill, then we can do this a second way, which is our nuclear way of doing this. So we can give nuclear isotopes, so radioactive isotopes to a patient where we can visualize function of the heart, so muscle contraction and blood flow. And then we can give drugs to simulate the exercise component. So we can stress their body in order to visualize what goes on in the heart when it's under stress. For our conductive diagnostic exams, we're looking at our EKGs or ECGs, same. It's electrocardiogram. So if you're of German descent or you like German things, it's an EKG because they spell cardio with a K. In the US or in other cultures, we spell it with a C. So cardiogram, ECG, both terms are used fairly interchangeably. And then telemetry monitoring. So these are two different ways of measuring electrical activity in the heart. This is the more detailed picture. This is the more generalized picture. So this is what we tend to call a 12-lead EKG. So it's our very detailed. We're looking at the heart from 12 different angles. Telemetry tends to be like a 5-lead. So it's half the resolution or half the imaging that a traditional electrical examination would have. So then we've got our super common medications that we give for patients with heart disease. So all of these different drugs, we're not going to go into them in huge detail, but I do want to show you guys that these different drugs work in different ways, all around different phases of our cardiac cycle. So our sodium channel blockers are going to impact kind of the P wave or the early phase of our cardiac cycle. Our calcium channel blockers are going to work after our QRS complex, so that ST segment. Then our potassium channel blockers, they're really going to impact our T wave kind of area, ventricular repolarization. And then our beta blockers, they're going to work in the gap between heartbeats. Okay? So we're going to talk a lot more about this and these drugs in particular in MedSurg 2 when we get into the electrical pathways. But for now, just to kind of give you the lay of the land, because I know you guys are learning about these drugs in pharm, so now you can see kind of why we have so many different cardiac medications and which part of the cardiac cycle they really do try to address. So that's our overview for a lot of the cardiac stuff that we're going to be covering in this class. Next, we're going to dive into the disease-specific content.